Okay, so welcome everybody to the Renal Association and BRS, British Renal Society webinar on guidelines. I hope all the IT is going to work. I'm Mike Robson. I'm a nephrologist at Guy's, and I'm going to be joined to chair this webinar by Katie Fielding, who's a renal nurse in Derby. And I'm going to give a very brief overview to start with of what the guideline committee does, and hopefully encourage contributions and participation from members. That'll be very brief, and then we're going to have four talks to present and highlight recent guidelines that have been produced, with plenty of opportunity for questions and things at the end. So very briefly, what the guideline committee actually does, I've listed the things that we do there. So we have a think about which guidelines can be produced, and it's really important that we have suggestions from people for that. So that's one area that we're really keen to have ideas. And having decided that a guideline would be a good idea, we now sort of invite expressions of interest, and that should be sent out to all RA and BRS members, and then the committee will look at the expressions of interest that come in and try and make a fair sort of decision based on interest and expertise as to who should be asked to write them. And then we monitor the progress of the guidelines, and that's a combination of encouragement, hassling people. I'm sure a lot of the current authors will will agree with that, just to try and help as much as we can to get the guidelines through. But the people that really do the work are the authors themselves, and it's a huge amount of work that people do in their spare time effectively. We also ensure the guidelines are produced according to the processes in the manual, which has been approved by NICE. And this is really important because I think it gives our guidelines a real validity, and there are certain requirements that include having patient and multidisciplinary team representation on the author panel, having a robust method for searching the literature and for evaluating the evidence, and also particularly important is the conflict of interest policy. So that's the NICE approved process which we currently have. And then the final bit, which is also important, is to invite comments from the renal community, and then to ask the authors to address these. And it's very much in the way of any other publication would be assessed. We need to, the authors are writing these guidelines on behalf of the renal community, and we need to make sure that any concerns or questions or suggestions have been considered and rebutted or incorporated into the guideline. I'm not going to read out all the names, but these are the current members of the guideline committee. And as you can see, there's a fair mix of nephrologists. We have two renal nurses. We have a patient representative. We have a pediatric nephrologist. We have a pharmacist and a renal trainee. And this is a screenshot, if you haven't been there recently, of the Renal Association guideline page. And I think it really highlights a huge amount of work that everybody has been doing. So you can see that in the last year, since June 2019, there have been around 10 guidelines or commentaries produced. And one point to make is that what we're doing now, if an organisation such as KDIGO or NICE have produced a guideline on a topic, then it doesn't really make sense to start from scratch, review all the evidence and do a full guideline. So we are producing commentaries which essentially look at the guideline and decide if and comment on whether there are any differences in reflection to UK practice. So they're the ones that are coming through, and the four that you're going to hear about today are four of the big substantial guidelines that are amongst those, four of the full guidelines. And this is what's coming through, just to give people an idea of what's coming through. The two that are in bold on exercise and lifestyle and vascular access are full guidelines. The others, as I've mentioned, are commentaries. So these are all commentaries on guidelines by other organizations. And I mean, two haven't actually been published yet. So KDIGO are producing guidelines on diabetic kidney disease and glomerular diseases. And we will be asking for expressions of interest to comment on those once they've been published. And just before I hand over to our speakers, just a few thoughts on guidelines. So I'm not going to give a long discussion on the pros and cons of guidelines, but and you know, I'm not going to read out these quotes, but the first one that you can read there really just says that you can use guidelines as something to help tell you what to do, but often there isn't an awful lot of evidence. It's probably a good thing to follow them if there isn't much evidence. It gives us some idea what people who are experienced in a certain area are doing, but it's often based on a paucity of evidence. The second quote is really making the point that if none of us can know about everything, so if we're looking after patients in an area where we're less expert, then guidelines are probably very useful, and it's good to follow them. If you know a bit more about something, then you can use a bit more flexibility with the guideline as something to get you started. But it doesn't actually follow that a guideline will fit every situation. And the last quote, I think, really just speaks to the importance of a conflict of interest. So this is a quote from a rather jaded editor of the New England Journal who ended up feeling she didn't trust a lot of clinical research and didn't really believe in guidelines. And she was really talking about the conflict of interest. And a lot of guidelines that are produced, the authors have substantial influence from pharmaceutical companies. And I think a particularly important part of what we do with the RA and the BRS is our conflict of interest policy, which links in with the NICE accreditation. So that's all I had to say, really. So I'm now going to hand over to Kate Fielding, who's going to introduce our first speaker. Katie.
Lovely, thank you, Mike. So I'd like to introduce Suren Kanagasundaram, who is a nephrologist in Newcastle and has worked there since 2004. He's also an honorary lecturer at Newcastle University, and he was involved in the NCE pod report that was put out with regards to acute kidney injury. His research interests are AKI, haemodialysis and critical care nephrology, and he is the lead author of the AKI Renal Association guidelines, which were released last year. So I'm going to hand over to you, Suren, just to go through your presentation first of all. Thank you.
Well, thank you very much, Katie and Mike, for the invitation and this opportunity. In this webinar, we'll be examining some of the key features of the latest clinical practice guideline for acute kidney injury, published in August of last year. Its scope, changes from the previous guideline, and any controversies that we came across. We'll also see how it lies within a really busy landscape of other guidance and clinical resources, and hopefully see what additional benefits it might bring to the table. So, in common with many others in the current crop of Renal Association guidelines, we expanded the number and range of authors to make sure that we had diverse enough experience to give us meaningful consensus. So, starting from the top left, you can see here we have patient representation, pediatric input, clinical pharmacology, and on the right, adult nephrology, representing a range of different types of adult practice. We hope that stakeholder input at both the scoping and review phases helped extend scrutiny over the course of development of the guideline. This talk does come with a warning, though. Its main focus will be on adult rather than pediatric practice, in large part to avoid doing a disservice to my pediatric colleagues. Any major differences, though, often boil down to the additional safety nets needed for pediatric practice and the lower patient numbers that allowed the more detailed audits that you could only get from individual case note reviews. So, in terms of scope, our starting point, as shown in the left-hand panel, was the prevention, detection, management, and follow-up of AKI in adults, children, and young people in primary and secondary care, with a primary focus on the common causes of AKI, ischemia, sepsis, drugs, etc., etc. We had a secondary focus on rarer causes, but only in as much as to highlight any clinical pointers towards these. The scope was to exclude neonates and adults at risk of contrast nephropathy, for whom joint guidelines existed at that time. So a consultation was undertaken, with the proposed scope being posted on the RA website for a 10-week period before confirming the final range of topics, as shown in the text box just over on your right. So our literature search strategy and search terms are spelled out in detail in the guideline appendices, and I won't go into them, but the historical reach of the searches was limited to 2011, based on an assumption that most current evidence up to that year would have been available for, firstly, the last Renal Association AKI guideline published that year, and secondly, the KDIGO Clinical Practice Guideline for AKI published the following year in 2012, which included a very detailed and comprehensive search strategy. We reran our search strategy partway through guideline development, aware of the vast literature that was being generated at the time. 7 new AKI publications each day, according to one estimate from Louis Forney. So I've already alluded to the complex and shifting landscape within which the CPG, the Clinical Practice Guideline, was being developed. Within the UK alone, our guidelines sat between both the 2013 NICE AKI guideline and the ongoing outputs from the Think Kidneys programme. We were very aware of the need to complement rather than contradict, bridging the gap between the predominantly practical approach of Think Kidneys and the evidence-driven methodology of NICE. The dynamic environment within which we're working is illustrated by the release of the latest NICE update on AKI, published just last December, just up there at the top right, and the anticipated appearance of the KDIGO update on the global stage. We felt, though, that a key role for our guideline was in the development of our audit measures, which were formulated together with the UK Renal Registry to allow practical, comparative assessment of AKI care and help drive its improvement. We hope that these measures might supplement the comparative data now appearing from the UK Renal Registry. I note that our audit tool has actually informed the Renal SPR Club's network programme of work for this year, which many of you will be involved in. Audit measures were chosen either based on their ease of automation, for instance, daily use and ease following AKI detection, or where individual case note review was deemed to be unavoidable by identifying a single audit population across which several different measures could be assessed. Where possible, we sought to identify individual measures that might represent broader AKI care processes. So, for instance, documentation of a differential diagnosis implied that a thought process had actually followed a new diagnosis of AKI. Looking over to your top right, the blow-up illustrates our different data sources. The UK Renal Registry has linked data extracts, which were utilised heavily for the latest Renal Registry publication on AKI alerts. Local data extracts, such as clinical biochemistry, local clinical records review, and specialist team audit, for instance, on prescribed renal support dose. Importantly, feedback from the network programme, which I understand is due to reboot very shortly, may well prove valuable in identifying practical barriers in running the full suite of audit measures. So the first topic we're going to cover is definition, epidemiology and outcomes. There's been no change in our recommendation to use the KDIGO definition, but we now also recommend applying serum creatinine criteria as per the NHS biochemical detection algorithm. Both seem obvious given that there's international consensus for the one and a national mandate for the other. As you may know, there is room for interpretation in KDIGO about how exactly you determine baseline creatinine, but the NHS England algorithm forces a solution to this to allow automated alerting. We've made no recommendations in relation to other biomarkers. We note the Think Kidneys position statement on the use of oliguria to detect AKI and quite clearly agree that this is an essential bedside tool. But the only reason to raise this issue as a potential controversy is to echo their own highlighting of epidemiological uncertainties, given the limited and in places contradictory evidence base on how well urine output and creatinine criteria calibrated. How they calibrate in terms of the disease severity that each criterion represents and the outcome that it predicts. This is the case for the big database studies, which require assumptions to be made about body weight and hourly urine flow rates, but also in the critical care literature where urine flow rates are those that are actually observed rather than just being assumed. Reliance on rises in serum creatinine does carry the risk of a missed opportunity for treatment, a missed opportunity because of the time lag between the renal insult and the diagnostic rise in creatinine, which is usually in the order of around 48 hours. This has produced a wave of interest in a variety of early biomarkers for acute kidney injury, either as a quote-unquote quick creatinine, such as cystatin C, or a marker of cellular injury, such as NGAL. We were unable to make a recommendation on the routine use of these biomarkers, though, because as well as the uncertainty about how and where to deploy these tools, no one test fulfills all the desirable characteristics of the ideal biomarker. This view is in keeping with NICE diagnostic guidance published just last month, actually, on the use of various biomarker platforms for AKI risk assessment prior to critical care admission. Finally, we reviewed evidence for electronic alerting for acute kidney injury. And although a uniform detection algorithm is now mandated across England and Wales, the end user interface may still vary, for instance, in terms of how intrusive the alert is, its mode of delivery, and whether interaction with the alert is mandatory or not. But even a single uniform interface may not suit all circumstances, even within the same organisation. In addition, evidence of efficacy, as many of you know at this stage, is limited and somewhat conflicting. The social factors underlying these mixed results are now being explored, although the ideal balance between alert intrusion and the clinical benefit remains unclear. The relevant audit measures require categorization of AKI in 3 different ways, as shown just above the table and underlined in red. So community acquired, never hospitalized; community acquired, subsequently hospitalized, that's AKI detected either in the community or within 2 calendar days of hospitalization; and hospital acquired AKI developing in hospital after the 2nd calendar day of admission. So the rationale behind the 2 calendar day threshold was that HES data do not include accurate admission times, preventing use of a more precise time frame, such as, for instance, 24 hours post-admission. But another important definition is that for renal recovery, underlined in red partway down the table, and which we've defined as a return of serum creatinine to within 150% of the baseline value. The Acute Dialysis Quality Initiative, or ADQI consensus group, that have had prolific outputs for nearly 2 decades now, developed a set of criteria for renal recovery that included this, plus proteinuria, plus hypertension. But given our goal of automation of data collection and audit, we took a pragmatic standpoint of using the creatinine-based criterion only. Moving on to the recognition of the patient at risk of AKI, we have previously recommended that they be identified by the most appropriate risk factor profile for the clinical setting. But where this does not exist, to use clinical judgment coupled with an awareness of generic risk factors for AKI. To this, we now also recommend enhanced monitoring for acute kidney injury using creatinine and for inpatients urine output until 48 hours, that kind of radio silence that we get from renal insult to creatinine rise, until 48 hours after a period of heightened risk has elapsed. The risk of developing ischemic AKI is influenced by a variety of factors, and as shown in the left-hand panel, these can be divided into pre-existing susceptibilities, for instance, advanced age and CKD, and exposure to acute insults such as hypovolemia and sepsis. But this distinction is a little artificial in that certain factors may both increase susceptibility, such as the long-term prescription of an ACE inhibitor, and act as acute triggers, for instance, their recent administration in a susceptible patient. So we're all well aware of the horror stories of potentially avoidable AKI that were graphically illustrated in the 2009 NCPOD report, and before that from work done by Paul Stevens and colleagues in Kent and Canterbury. However, we recognise the difficulties in routine use of these risk factor scores. So if you look over at the right-hand panel, firstly, most AKI risk scores have not been externally validated, and those that have may not perform well across similar populations at different venues. So these scores are often not good travellers. Secondly, these tools often do not discriminate those at highest risk. Robson et al., for instance, in a study performed across 4 South Wales emergency admissions units, found that 63% would have been categorised in the high-risk group using a standard list of risk factors. Risk scoring tools for acute kidney injury should be practical. Exhaustive checklists for AKI risk factors may be unhelpful or even potentially counterproductive. The law of unintended consequences, depriving people of essential treatments and investigations. And in addition, AKI risk factor profiling is intended to stimulate an appropriate clinical response. And this becomes a problem when these tools are being interpreted by relatively inexperienced frontline staff who need to balance complex and competing risks. And finally, we ask, how should a high risk for acute kidney injury be communicated over the course of a single hospital journey, from one shift or one ward to the next shift or ward? And how should it be adjusted as the clinical situation changes? So Given that one-size-fits-all risk scores, even for disease-specific settings, are unlikely to materialise in the near future, we also believe that obviously robust AKI educational programmes should include discussion of the complexities of identifying and managing the at-risk patient. And it is kind of with this quandary in mind that the audit measures have been formulated to try and best reflect care processes, but also to help identify those systems that lead to best performance. So good performance may of course be represented by the incidence of AKI in any one clinical setting or organisation, but also by the initial stage of AKI at first diagnosis and how frequently serum creatinine was being monitored beforehand. Moving on, the Think Kidneys Minimal Care Bundle forms the basis of the section on clinical assessment, history, examination and investigations. The evidence base underpinning our recommendations is not strong though, and derives largely from a consensus on best practice. These recommendations are also targeted for patients at heightened risk of acute kidney injury. One audit measure, documentation of a differential for the AKI, as mentioned just at the start of the talk, implies that the episode has not only been recognised, but that a search for its cause has been initiated. Our recommendations on management apply to patients at high risk of AKI as well as those who have developed it. And with reference to the previous CPG, the new guideline ties in nice guidance on physiological assessment and fluid therapy. Evidence from RCTs assessing fluid prescriptions and AKI tend to be limited to specific settings, ICU, severe sepsis, or around interventions such as on the way to the cardiac cath lab. So no firm recommendations can really be made for common or garden everyday acute kidney injury beyond using existing NICE guidance. We discussed the avoidance of starch solutions and a positive fluid balance, both of which are now clearly associated with negative outcomes. We also discussed the KDIGO recommendation for protocolized management of hemodynamic parameters to prevent or mitigate acute kidney injury. Although a recent KDIGO controversies paper, first authored by Marlies Osterman, one of the co-authors on this paper, and highly commended to the audience, suggests that this is far from settled. But in health, renal autoregulatory processes, as you know, maintain GFR when the MAP is generally about 65 millimeters of mercury or above, a target we felt was reasonable provided it was taken in the context of the patient's pre-morbid BP, their comorbidities and their current volume status. The tie-in with NICE recommendations on fluids and physiology is reflected in the audit measures attached to these recommendations. The second of these relates to documented volume assessment, and we come across a bit of a stumbling block here. We noted the difficulty in defining the components of an adequate volume assessment and took the view that the occurrence rather than the actual quality of the review was all that could be established for the specific audit measure. For instance, a narrative description from a senior clinician, quote unquote dry or quote unquote volume overloaded, would be difficult to fault from an audit perspective, whilst documented evidence of a chest and cardiac examination by a less experienced clinician might not necessarily imply that its intent was to actually assess volume assessment. But despite these ambiguities, we felt it was important to include audit of timely volume assessment, given its crucial role in AKI management. Moving on, inappropriate drug dosing in patients with AKI is an important cause of adverse drug events. Pharmacokinetics, including volume of distribution, clearance, and protein binding, are all altered by organ failure, particularly in the critically ill patients. Drug doses need to be adjusted with as accurate an assessment of kidney function as possible to reduce toxicity on the one hand as renal function falls, and avoid underdosing on the other hand as it rises on recovery. In the new guideline, we recognise the dynamic nature of AKI by also including a recommendation on the need for regular re-evaluation of drug dosing as renal function waxes and wanes and as renal support is initiated, altered, or discontinued. We have also added guidance on the re-AKI or period of increased risk of developing it. The single audit measure attached to this topic does not, however, relate to management of medicines after AKI is established, but rather to the review of medication when it has been first diagnosed. The first audit measure attached to the topic of nutritional support relates to our recommendation that patients with AKI receiving renal support should be referred to a dietitian for individual assessment. Malnutrition, as you know, particularly protein energy wasting, is very common in the setting of AKI and has been identified as a predictor of in-hospital mortality independent of complications and comorbidities. The recommendation for formal dietetic review only after starting RRT represents, in the guideline development group's opinion, a balance between the practicalities of resource limitations. After all, there's only a finite number of dietitians. The fact that this is the higher risk group for malnutrition, and because the evidence base for dietetic intervention with less severe AKI is still lacking. Our recommendations on treatment facilities and patient transfer mirror those from the previous CPG, accepting some updates that we've brought into the news era. Our audit measures are geared to test safe transfer and adequate renal resourcing. We move on now to renal support. There's an obvious discrepancy between the large number of recommendations and the single audit measure related to RRT dose. But one thing that we noticed heading into the latest CPG was the relative dearth of new publications on renal support for AKI in comparison to what was appearing on the landscape in previous guidelines. So our view on issues of modality choice, membranes, and fluids remains largely unchanged. We do not alter our view on renal support dose either. The two large multi-center RCTs, the ATN and renal studies, were both negative in terms of an advantage of high versus lower dose. These findings informed our previous and current recommendations, but it's important to emphasize that not the dose does not matter, but that there is a minimum dose below which you should not fall. So this is particularly important to emphasize because renal support, and particularly IHD, and we see this in local audit after local audit, tends to be both underprescribed because we fail to appreciate disordered volume status, catabolism, and poor vascular access, but also under-delivered because of poor flows, CRRT downtime, circuit and membrane clotting, etc., etc. And these deficiencies are compounded by a failure to monitor dose delivery with each session of IHD and after each day of CRRT. We continue to avoid a specific cut-off urea for initiation of renal support, but specific changes in this guideline and the present guideline include, firstly, the introduction of a recommendation on the use of antimicrobial locking solutions, and secondly, the strengthening of our recommendation on the use of regional citrate anticoagulation, which we now believe to be the first choice for CRRT circuit patency, given the widespread use of hardware that offers this as a very low-risk solution now. Our final topic up for discussion is discharge planning. Our various recommendations are tailored to ensure pertinent information regarding inpatient AKI is conveyed to primary care, that appropriate renal follow-up is arranged, and that relevant drug advice is provided. The related audit measures test these, but you may well be aware of guidance published by the Royal College of GPs just last November. This data details the additional steps that primary care should be undertaking in following up a patient themselves who has been discharged after an AKI. We hope that our own recommendations complement this guidance from a secondary care perspective. So this ends our quick review of some of the key features of our new AKI CPG, and I'd be happy now to take any questions. And there's a list of the extensive stakeholder scoping that we undertook over the course of guideline development. Thank you.
Thank you very much, Suren, for a really interesting talk. That was a really good summary of the AKA guidelines. So first of all, I noticed you talked about the Think Kidneys work with regards to assessment of AKI, and I do know that urinalysis is something that is quite important in terms of the assessment of AKI, but I also know myself when I'm working with nursing colleagues, actually getting them to think about urinalysis in that way rather than thinking about urinalysis and UTIs is really difficult. I was just wondering if you had any tips in terms of how we could improve that, whether that was a problem that you could come across yourself, those sorts of things.
Sure. I mean, it is a battle between our renal pet topic and the care of the elderly colleagues. I mean, I can only speak for our trust, and emergency admissions. The high-risk population get urinalysis at the door, and I guess then that's open to whichever specialty gets exposed to that patient. So an agnostic view, but I understand that there are conflicting standpoints on what you do with that information.
Yes, yeah. The other thing that really interested me about your talk was you talked about how urine output can be used to diagnose AKI, but this is something that when you've looked at the research, it's very difficult to actually calibrate it with that diagnosis. And I know myself, again, as a renal nurse, how difficult it can be to get an accurate urine output. I was just wondering, when you looked at the literature, whether there were any sort of factors identified that sort of told us why we weren't getting that calibration with urine output, what it was that was causing that.
Yeah, sure. So that's a really important question. And I think at this stage, urine output is I mean, of course, it's a really important bedside tool, but what does it mean? You know, it's dramatic enough to have to excite a clinical response. I did mention the big database studies, and they have to make assumptions about what's happening on an hour-by-hour basis. You know, normalizing a cumulative daily total, for instance. Assuming a standardized body weight, and we know that these lead to inaccuracies. But if we look at the critical care literature, who clearly have, you know, really high quality urine output, urine flow data, it's quite a mixed bag. That, you know, not everybody who develops AKI by oliguric criteria go on to develop a serum creatinine response, and perhaps what we're seeing is actually some different pathology, different cohorts being described. So a strictly pre-renal cohort who very quickly respond to volume, or perhaps the you know, the physiological post-op, post-trauma patient who shut down their urine output without any problem with the kidneys. And so yes, it's a great clinical tool. And I suspect that there will be no one-size-fits-all for urine output criteria. It'll vary from population to population. So trying to cross-calibrate it and get a one-size-fits-all cross-calibration, I'm not sure that we're ever going to achieve.
Okay, that's fantastic. Thank you, Suren. So I've just had a question come up here, which says, what are your thoughts on the review update process for the AKI guideline? You told us about the volume of evidence being published. Have you a mechanism for updating when new evidence appears in a way that is light touch for the guideline group?
Sure. And again, that's such an important question. I don't think there's a formal mechanism for undertaking that in terms of you know, guideline group review of the existing literature, and perhaps that needs to be built in, you know, formalized, you know, particularly for the high volume literature. The peer review process is critical as well, and you know, I think we know how busy everybody is, and faced with a 120-page guideline to review, you know, you have to be pretty robust to go through that in detail and critique it. So perhaps you know, there is a role for a formal external reference group to you know, review each guideline, but you know, that's only a thought and suggestion.
Yeah, I'm going to hand over to Mike, who's got their next talk online for that now. Thank you.
Great,
very much.
thank you very much. Thank you, Sarah, and a great talk, and thanks, Katie. So I'm going to now introduce our next speaker, who's Annette Alfonzo, who's I think I've got the order right there, haven't I? Yeah. So Annette is a consultant nephrologist from Victoria Hospital in Kirkcaldy. She's also clinical director there. She has a special interest in renal emergencies. She actually wrote the guideline or co-authored the guideline as lead in 2014, and has just done the same again, and that's now live on the website. She's also a faculty member of the European Resuscitation Council Guideline Committee. And please do ask questions as we go along if you have them, and then we can go through them at the end. So Annette, over to you. Thank you.
So thank you for inviting me to contribute to this webinar on behalf of the Hyperkalaemia Writing Group. And we have no conflicts of interest. So hyperkalemia is a common and potentially life-threatening medical emergency, and it crosses all specialty barriers and all grades of medical staff. So at some point, every clinician will be faced with a hyperkalemic patient. It becomes more relevant in recent years, I think, because of the increasing use of RAS inhibitor drugs for a wide range of clinical indications, but hyperkalemia has limited the optimization of this drug therapy, especially in patients who benefit the most. Recurrences are very common, therefore monitoring and prevention are really important. So we feel that a standardized approach in both the community and the hospital settings can reduce harm associated with hyperkalemia itself, as well as its treatment, in particular hypoglycemia. So you may be familiar with this patient safety alert, and that was put out to all 232 NHS England hospitals and GP practices following 35 reports of cardiac arrest in patients who were hyperkalemic. Delays in recognition, initiation of treatment, and monitoring were common themes, and this alert really highlights why the treatment of hyperkalemia is time sensitive. So on this background, the first step is really early recognition. And following Suren's talk, clearly the group of patients that we need to think about are those with an acute kidney injury, patients with chronic kidney disease, particularly those approaching the need for dialysis, all dialysis patients, the ones with diabetes, heart failure, and any patient with a significant crush injury that may cause rhabdomyolysis are at risk. And when you see these patients, if they have any evidence of muscle weakness or paralysis, alarm bells should be ringing almost immediately. It's important to get an urgent potassium, and the best way is using a blood gas analyzer, and that will also tell you the severity. The ECG is very important, and in 2/3 of patients with severe hyperkalemia, you're likely to have some ECG abnormality or a combination of several. And as hyperkalemia becomes more severe, the ECG changes progressively and ultimately may result in a cardiac arrest. It is important to say that the ECG may be entirely normal, or there may be atypical features despite severe hyperkalemia. So treatment, it's guided by the severity, the acuity of the patient, and the likely etiology. So the approach to treatment that we've addressed within the guideline, we've used 3 different clinical settings, and that's the difference between the current guideline and the previous, which was largely based on the hospital setting, and this guideline has defined it into 3 clear sections. So firstly, in the community. So hyperkalemia is often an incidental finding in a clinically well patient. They may be coming to a GP surgery to have some bloods done, or coming to an outpatient clinic. And many of us have had calls during the evening to let us know about an abnormal blood result. And it raises a few key questions in this scenario. What's the threshold for treatment? When do I admit a patient to hospital? When can these new binders for lowering potassium be used, and how do I choose between them? And then how often do I monitor the potassium after an episode of hyperkalemia? So when do we start treatment? Every clinician has their own idea on this, but I think it's reasonable to suggest that a potassium above 5.5, which reflects mild hyperkalemia, is a time to consider doing something about it. If the patient is clinically stable, then having a look at their medication and potentially looking at the combination of drugs that they might be on, which might be exacerbating it, is the first step. Then turning to their diet, and perhaps with the help of a specialist dietitian, reviewing whether there's any adjustments required. Assessing their metabolic status and treating it if necessary, and considering diuretic therapy. Hospital admission, or at least assessment, is required when the potassium is above 6.5 millimoles per liter, even in a well patient. Other patient groups that require hospital assessment or admission is if they're acutely unwell or in the presence of an AKI, and this is true at all levels of hyperkalemia. And that is because of the risk of potential deterioration. So turning to the use of potassium binders. So this is new to all of us, and there's lots in the literature, and it's been a very good advance for treating hyperkalemia. Patiromer, also called Veltassa, and sodium zirconium cyclosilicate, otherwise known as Lokelma, have both been approved by NICE for specific indications. So patients with stage 3B CKD to stage 5 who are not yet on dialysis, or patients who have heart failure, are potential candidates if they fulfill two further criteria. The potassium needs to be persistently at or above 6, and they have to be receiving a suboptimal dose of RAS inhibitor therapy. These drugs can only be started in secondary care, although we will need some help from primary care with the monitoring. If patients don't fulfill these criteria, then we're in the realms of what we do now, either reducing or stopping the RAS inhibitor and continuing to monitor. For patients who do receive these drugs, keep in mind that it may not work, so it's useful to monitor the efficacy, and it may work too well, and the patient may become hypokalemic and a dose adjustment is required. Bearing in mind, if you stop the binder, the patient may have a rebound in their potassium. So always think about prevention in patients with hyperkalemia. If they've had one episode, they're very likely to have another. So now looking at choosing between the binders. So it's well established that Lokelma works more quickly and reduces potassium by 1.1 millimoles per liter within the first 48 hours. And within that time frame, about 75% of patients have achieved a normal serum potassium. In contrast, the alternative drug Veltassa produces a more modest reduction in potassium at around 3 days, and it can take up to a week to really get the potassium within a normal range, and a reduction of a similar level at 4 weeks. But both drugs are able to achieve continuation or titration of a RAS drug. So choosing between the two may fall to whether there's a difference in administration. For example, Veltassa binds to a lot of other drugs, so you might want to think about that when you choose this option. Or you might want to consider the risk of exacerbating edema in somebody who is at risk of fluid overload if using Lokelma. Patiromer also causes a high calcium in some patients, and this has been recognized in the literature, and it may lower the serum magnesium level. But on balance, in the community, I would say the scales are probably equal for both of these binders in the community setting. It's important to acknowledge that while you're optimizing the RAS-ITIP therapy, it's a reasonable chance that in some patients, you may find a worsening of the renal function, even though the potassium may look great, the creatinine won't. So turning to blood monitoring, the frequency of monitoring in the community really is guided by the severity of the hyperkalemia, the clinical condition of the patient, and whether they have an AKI or not. Patients with moderate hyperkalemia pose the greatest dilemma. The potassium is not high enough to admit them if they're well, but it's too high to ignore it. So these patients warrant a repeat blood test within a day, and you have to come up with a treatment plan thereafter, and you might want to include a potassium binder if the patient fulfills the criteria outlined by NICE. At all severity groups, you have to consider what may have caused the episode and try and do something about that. This is compatible with the Think Kidneys guideline and has been also considered some of the literature on monitoring. So turning to the hospital setting, treatment is guided by the severity, the rate of rise in serum potassium, the acuity of the patient, and the approach is also different if you're dealing with a dialysis patient, because medical treatments will only temporize until you can get on and start dialysis. The Renal Association guideline follows a simple 5-step approach, and I'll give you an outline of that. And we've also incorporated 2 significant changes in the current guideline. We've amended the insulin glucose protocol, and we've incorporated the use of the novel potassium binders in the emergency setting. So following initial assessment, the first step in managing hyperkalemia is protecting the heart. There's been a lot of debate over the years about which ECG signs warrant IV calcium. Another factor is that ECG interpretation is very variable depending on the skill of the clinician. The evidence is predominantly anecdotal, but in general, it's accepted that IV calcium is warranted in the presence of ECG changes. The 2014 and current Renal Association guidelines recommend giving an equal amount of the gluconate or the chloride salt. So that means you would need to use 30 mils of 10% calcium gluconate to give the same dose as 10 mils of 10% calcium chloride. And the reason that that change was made is that you frequently need to give more than 10 mils of calcium gluconate to reverse the toxic ECG changes. And indeed, an early guideline from another group recommended giving up to 5 doses of gluconate if required. So the effect of IV calcium is probably best demonstrated by a couple examples in real patients. So this 64-year-old man who was on holiday in sunny Scotland became unwell after combining an anti-inflammatory drug with a ACE inhibitor, possibly after climbing too many Munros, and he presented to an ED with paralysis and this ECG. Unfortunately, blood tests were not immediately available, but there was an astute clinician who spotted a few abnormalities in this ECG. Tented T waves, a very broad QRS complex, and no P waves brought them to the conclusion that this could be hyperkalemia. They gave IV calcium, and there was no change, and gave a further dose, leading to quite a dramatic improvement in the ECG. But it did take a repeat dose to achieve that. Sometime later, the potassium came back and confirmed a severe AKI. This is the ECG used in the current ALS manual if you'd like to have a closer look at it. The next patient was a 24-year-old dialysis patient who missed 2 consecutive sessions because of his busy social schedule and came into ED as a standby call with severe limb weakness and an ECG showing ventricular tachycardia. There was a blood gas machine, and that showed a potassium of 9.1. Again, he required 2 doses of IV calcium, and he cardioverted to sinus rhythm without needing amiodarone. Although IV calcium does not lower the serum potassium, it does buy time to allow other measures, such as insulin dextrose and salbutamol and other drugs, to lower the serum potassium. So turning to insulin glucose, this is the most effective and well-established treatment for lowering potassium in the acute setting. However, the most common adverse effect is hypoglycemia. So when coming up with a new guideline, it was very difficult to not address this in light of all the recent literature highlighting this major problem in at least 1 in 4 patients using the conventional regime that we've used for decades. And this is avoidable harm. Although some studies have showed a reduction in hypoglycemia with the low-dose insulin protocols, the incidence is still quite high, and it's up to 19% when using just 5 units of insulin. And the evidence also suggests that a low pre-treatment blood glucose below 7 is a consistent risk factor for hypoglycemia, and that identifies a group of patients that would benefit from additional measures to prevent hypoglycemia. So the optimal treatment regime for insulin dextrose should reduce the incidence of hypoglycemia, but without compromising its efficacy, because this will also affect patients with life-threatening hyperkalemia. So although some studies have suggested low-dose insulin has equal efficacy, there are 2 studies that reveal a dose-dependent effect of insulin. The first study shows a trend in patients with a potassium of greater than 6. The second study, which was published earlier this year, is the largest study, including 700 patients, conducted of insulin glucose therapy and showed a significantly greater potassium reduction in patients treated with 10 units compared with low-dose insulin. So this evidence provides a rationale for maintaining the dose of insulin at 10 units. So given that lowering the dose of insulin doesn't reliably reduce the incidence of hypoglycemia, the alternative approach is increasing the amount of glucose given. The method of delivery is also important, as a lower incidence of hypos tend to occur when glucose is administered continuously, as in this study. The rate of hypos were closer to 6%. So this provides the evidence and rationale for giving the standard dose treatment for all patients, but giving a background infusion of a further 25 grams of glucose over 5 hours in the patient group most at risk of hypoglycemia. So how do we use the potassium binders in life-threatening hyperkalemia? They've both achieved nice recommended use within this setting, but in reality, they work quite differently and at different speeds, and that is very relevant in someone in this situation. Lokelma has a more rapid onset of action than Veltassa, with a greater potassium reduction within the first 24 hours. The median time to normalizing a potassium with Lokelma is within 2.2 hours, and its efficacy has also been shown to increase with worsening severity of hyperkalemia. So on balance, the scales tend to tip in favor of Lokelma being more suitable for emergency management than Veltassa, but both drugs might have a useful benefit in preventing or at least dampening down the rebound that we often see once insulin glucose and salbutamol wears off in and around 4 to 6 hours after treatment. So the hospital algorithm incorporates all of these principles, using drugs to shift potassium back into cells, interventions to remove potassium from the body, including the use of binders. Dialysis may be required at the outset or if medical treatment fails. We also have a useful guide to when the potassium and glucose should be monitored, but never walk away until you have considered how you can prevent a further rise or recurrence of hyperkalemia. The most feared complication of hyperkalemia is cardiac arrest. Prompt recognition and treatment of hyperkalemia are the key steps in preventing this from happening. There's very little evidence base in this situation, so all the treatment recommendations are really extrapolated from the non-arrest situation. Dialysis during CPR, ideally supported by ECMO, may be an option in selected cases, depending on the availability of equipment and expertise. The largest study of hyperkalemic cardiac arrest was reported in 2016. This study included 109 patients treated with only medical intervention. And there are a few key and interesting observations in this study that might suggest that dialysis is a treatment modality for refractory hyperkalemic cardiac arrest. So patient outcome in this study was divided into 3 severity groups. In the lowest severity group, 44% of patients achieved ROSC, which is return of spontaneous circulation for more than 20 minutes. But of those patients, only 18% were still alive at 24 hours. In the intermediate severity group, 23% of patients achieved ROSC, but only 7% were still alive at 24 hours. In the highest severity group, only 1 patient achieved ROSC and did not survive at 24 hours. So the key observation is that the chance of achieving ROSC goes down as potassium gets higher. Sustaining ROSC was also poor at every severity group, with a drop of how many people are surviving to 24 hours. And that might indicate the need for urgent dialysis post-arrest. No patients in the extreme category were able to sustain ROSC, and that would suggest that drugs alone is insufficient to achieve or sustain ROSC, and that might be an indication for considering dialysis. So medical interventions follow the same principles as in a non-arrest situation. We would give IV calcium, insulin glucose, and sodium bicarbonate. And if ROSC is achieved, then we follow the post-arrest protocol. If ROSC is not achieved, then by 15 minutes into the cardiac arrest, the team should be seeking expert advice and considering whether dialysis is either appropriate or technically feasible. The Renal Association guideline provides a summary of the available evidence and a practical approach to initiation of dialysis during CPR, including some important safety considerations. Consider that if it was worthwhile starting CPR in the first place, how far will you go? Would you consider dialysis in either the patients I described to you earlier, the 64-year-old chap from England who decided to travel to Scotland to climb some hills, or the 24-year-old chap who might be a candidate for transplantation if he can pull himself together and attend dialysis? Consider that other invasive strategies are used in cardiac arrest for other potentially reversible causes. We would stick a needle in the heart to decompress a tamponade. We would decompress a pneumothorax. We would put someone on cardiopulmonary bypass to warm them up. I've certainly done this using a hemofilter to warm up a hypothermic patient with a successful outcome, despite 5.5 hours of manual CPR and 3 hours of dialysis. And that patient has recently been in touch and she's become a mother, which is one of the highlights of my career. Why not consider the most effective intervention for hyperkalaemia, which is dialysis? Also consider the increasing use of ECMO to enhance resuscitation attempts. Like most things in life, you may not always succeed, but failure is usually guaranteed if you do not try. And I tell my children this almost on a daily basis. So looking ahead, the use of novel potassium binders is likely to evolve as we gain more experience in the use of these drugs. And hopefully, with the knowledge that these drugs are more tolerable than calcium resonium and have a stronger evidence base, we will have a wider scope to use it. Given that there's concerns about iatrogenic hyperkalemia or iatrogenic hypoglycemia, there may be a role for these binders in moderate hyperkalemia in the acute setting. And I strongly believe that if we had a 20% glucose solution in the correct volume for treating hyperkalemia, we would actually reduce the incidence of hypoglycemia, and we would actually be able to avoid the use of 10% glucose solutions in large volumes in patients who might be at risk of fluid overload. So we would like to thank Charlie Thompson, who invited me to lead the first guideline and has been an absolute delight and very supportive in the preparation of the current guideline. I'd like to thank Jazz Soar, who contributed to the resuscitation section of both guidelines. And I'll leave you with this picture of the Scottish Highlands while you consider any questions.
Great, thank you, Annette. That was a great talk, and I'd really like to encourage people to ask questions. We've got 178 people on the webinar at the moment, so please send some questions in. We have 2 already, and the focus is on potassium binders. So the first is from Jeremy Levy, and he's asking, really, should we be using calcium resonium at all rather than moving to newer agents for moderate hyperkalemia? So Annette, what do you think of that one? Is there any, what is the place for calcium resonium and why should we still use it at all?
I ask myself that question on a daily basis, and it's a drug that came into use and would never get past the FDA regulations now, and patients don't like it. It has significant problems. And the difficulty is that NICE has obviously approved it for the new binders for very restricted recommendations, and the Scottish Medicines Consortium has not approved either drug to be used in Scotland under any circumstances. So our ability to prescribe it is the limiting factor unless we choose to act out with national recommendations. But I think the evidence for these drugs are very clear, and there haven't been new developments for hyperkalemia in decades. And I think we really need to gain experience in using these drugs and fine-tune their use in the coming years. Great,
thank you. And on the same vein, we have another question about the sort of difference between the two. So they're saying that Lokelma has a maximum course of 3 days in the hospital setting. How long would you use patiromer for?
So I guess it depends on how long it takes to normalize the potassium. And you know, the evidence would suggest that looking at the rate that it works at it could take up to a week to normalize the potassium using patiromer. And the patients would need to be monitored, and a cause for the episode needs to be found. So stopping the drug in the acute setting will really depend on, have you removed the thing that's causing it in the first place? Is there an indication to continue it if the patient is on an ACE inhibitor for a really important indication like heart failure? Are you going to initiate it and send them home on it? And I think that is really the key thing. But certainly in the acute setting, sodium zirconium probably has the advantage given that it works more quickly.
Great. And I mean, comments on Resonium are still coming through. So just to be clear, it's still in the guideline, but I guess you're saying you would only ever use it if you were not allowed or able to use one of the new binders. So I guess the question is, are you happy it's still in the guideline at all if you're trying to say what's the best treatment for the patient rather than what's, you know, what are you allowed to prescribe?
I think that the difficulty is that calcium resonium, and it's a treatment that we know, and it's not one that we like, but in terms of ability to prescribe drugs, you know, we have to leave it there as an option for clinicians who work in areas where they don't have access to the other drugs. And I think that, you know, hospitals and perhaps wider organizations, including the Renal Association, perhaps as a group, we need to address the very narrow scope that we have to work with within NICE and SMC guidance.
And I guess in the same vein, you gave a very careful comparison of the two binders, and said that, you know, Lokelma was more effective, but surely in the emergency treatment of hyperkalemia, you would prefer Lokelma, wouldn't you? But the guideline kind of puts them on an equal footing in terms of them both being options.
It doesn't, because in the guideline, what we've said is that we recommend the use of Lokelma, and we suggest the use of the other option, Veltassa. Okay. And in the algorithm, we try to depict that with a different emphasis as well.
Okay, great, thank you. That's important to clarify. So there's a different wording. So you are suggesting
we took that into account. The weighting is completely different in the guideline, and I think that's actually quite clear.
Great. And I'm just looking to see if there's any other questions before we move on. One from Colin Jones here saying, nice, again, it's the new binders. So the new binders have been approved without any hard outcomes. And a Cochrane review has shown that there's no substantial evidence of their utility for acute or chronic hyperkalemia. Would you like to make a final comment on that, Annette? There's no evidence that they actually affect any hard outcomes as yet.
Well, I guess the ENERGIZE study for Lokelma in the acute setting would be helpful. And you know, I think at the moment, it's better than what we have now. And it's an adjunct to standard treatment, not a replacement. So I think at the moment, I would still suggest that we use this as an additional thing that we have that can help control it, and potentially help control repeated doses of insulin glucose being required as well. Because as time goes on, the binders will become more effective.
Great, thank you very much indeed. That's great. So we'll move on now to our next talk. So that's going to be on the guideline on pregnancy and renal disease, and that's from Kate Wiles. So Kate is a recently appointed as a consultant obstetric physician and nephrologist at the Royal London. She completed, or she had been doing her research, which she's continuing with at King's College London and Guy's and St Thomas's, and she's a member of the UK Expert Consensus Group on Renal Disease in Pregnancy. Kate, hand over to you.
Lovely, thank you, Mike. Thank you to Mike and Katie for the opportunity to present the guideline on pregnancy on behalf of all my co-authors, and Professor Liz Lightstone is also part of the panel today and is happy to answer any questions that you might have. So when we undertook this guideline, we had an aim to cover all aspects relevant to pregnancy and renal disease. So we wanted to address pre-pregnancy care, which is largely under the remit of the nephrologist, antenatal care, which comes under the remit of the obstetrician and the nephrologist, and also the fourth trimester, postnatal care. And we also wanted to cover all aspects of renal disease, so all stages of CKD, transplantation, dialysis, with a specific focus on certain conditions in which the management in pregnancy is different or more complex. And that includes lupus, CACUT, and urinary tract infection. And by covering all the aspects of pregnancy, including pre and postnatal care, and all stages of disease, and dialysis and transplantation, it's actually the first guideline of its kind in the world. So there isn't another guideline like this. There's a single guideline on dialysis and one specifically on glomerulonephritis, but nothing that looks quite like this. And in order to be able to do it successfully, we ran a multidisciplinary group of authors, including nephrologists, obstetricians, obstetric physicians, 2 expert midwives, and 3 expert patients. The problem when you come to write about pregnancy in general and pregnancy and renal disease specifically is that pregnancy is basically the black hole of evidence. And I can tell you, even having written the guideline, that there's no high quality evidence that the non-pregnant management of renal disease translates into improved pregnancy outcomes. And the data are largely generalized from management of normal pregnancy, which we presume applies to women with CKD, the management of non-pregnant renal disease, which we presume applies to pregnancy, and also looking at other conditions in pregnancy. And there's probably more data on chronic hypertension, some good data on diabetes, but also just looking at the management of medically complex women, of whom CKD is an apt description. And so these are the grades of evidence in the guideline. So the pyramid goes from A to D, and you can see that level A evidence, which is high quality RCTs or overwhelming evidence from another source, 1% of our guideline is based on that. And even that's generalized from women with diabetes rather than CKD per se. And actually most of the guideline is what, in terms of the hierarchy, you would call poor quality evidence based on small cohorts or randomized trials with flaws or expert consensus. And because of that difficulty, because a lot of it was looking at small cohorts and coming up with expert consensus, we wanted to make sure that this just wasn't a bunch of nephrologists, largely in London, who all work together and all whom are known to share the same practice, making decisions. And so actually, as part of the guideline process, we undertook a national electronic survey where we sent out our initial recommendations and asked for an opinion on agreement and also the provision of any comments. And that was hugely helpful. So to anyone who filled that in, I'm very grateful. And that went out through the Renal Association, but also we used the MacDonald Obstetric Medicine Society. We sent specific invites to known obstetric nephrologists with an interest in pregnancy, to the Consultant Midwives Group in the Royal College of Midwifery, and also to the UK Renal Pharmacy Group, because there's a whole section on medication use in pregnancy. And you can see, in fact, responding to the survey, there was only about half were nephrologists, so we did manage to get a multidisciplinary opinion, including obstetricians, midwives, obstetric or expert physicians, and pharmacists. And actually these were a really good bunch of people, because about 80% were regularly involved in the care of women with renal disease in pregnancy, and just over a third actually formed part of specialist obstetric nephrology MDTs. So these are the people doing the care in the country, so we felt that this was good expert consensus. So Mike asked me to address any new recommendations, and they're all new because it's a new guideline, but I'm just going to highlight some of the areas where we had probably most discussion amongst ourselves, but also within the feedback we got nationally. So I'm going to highlight pre-pregnancy counselling, medication, blood pressure, and then the management of dialysis and transplantation in pregnancy. So our pre-pregnancy counselling statement is that we suggest that pre-pregnancy counselling is undertaken by a multidisciplinary team that includes both obstetrics and nephrologists. And the reason we suggest it is because a suggested recommendation has unclear benefit and risk balance, and is the risk versus benefit is not clear for all patients. Now, that's a potentially controversial statement here, because this is counselling, this is information, and this is advice. So this surely is without risk to the patients. But the other element of this is you also have to look at burden and cost. And the problem is nationally is that this multidisciplinary team are not available everywhere. So you don't often get a consultant obstetrician and a nephrologist in the same room. And the other feeling, I have to say largely from nephrologists, is that CKD stage 1 is often uncomplicated, and most nephrologists don't worry about pregnancy going ahead in patients with uncomplicated CKD stage 1. But there is a second statement where we recommend that women are advised about their risk in pregnancy. And their risks in pregnancy include preeclampsia, fetal growth restriction, preterm delivery, neonatal unit admission, and caesarean delivery. And the data shown here are just two contemporary cohorts where they've actually looked at CKD stage and the risk of these events. And you can see that basically the risk of all of these things increases as your CKD stage increases. But although there is some evidence of CKD stage shift or a deterioration in renal function, either in pregnancy or postpartum, the majority of complications are actually obstetric. So all of these complications are obstetric. So you can't, we would argue that you can't really have this counselling without obstetric input. It's very difficult for a nephrologist to know what the implications and management of preeclampsia are, and to talk about the implications of preterm birth and what it's like to have a neonate who might be admitted for 2 months, and looking after that kind of patient, that kind of baby, and also the long-term complications of a caesarean delivery in terms of future delivery. So we would argue that you do need multidisciplinary counselling. The other thing is, what about CKD stage 1? Well, these data come from an Italian cohort, and this is 370 women with CKD stage 1 in pregnancy, and looks at a general combined adverse outcome. And that combined adverse outcome is all obstetric, so it's fetal growth restriction, it's preterm delivery, and it's neonatal unit admission. And it shows that actually, even when you have CKD stage 1, your risk of that general combined adverse outcome is increased compared to women without CKD. Even if you take away systemic disease, so this isn't all lupus, even when you take away women with significant proteinuria, even when you take away the women with hypertension and the women who were referred late. So there's something about CKD that confers risk in pregnancy, even when you have stage 1. So our recommendation is that it should be multidisciplinary, that you can't rationalise based on CKD stage. And although we've suggested it largely because of availability, in fact, we do recommend it for women who are particularly high risk for either obstetric complications or CKD disease progression in pregnancy. And that includes women who have an eGFR of less than 60 before pregnancy, anyone who's got progressive disease, because you've got 9 months for that to progress further, anyone who has uncontrolled hypertension, which from a pregnancy point of view is over 140 over 90 going into pregnancy, anyone with significant proteinuria, active renal disease, lupus, all the transplants, and anyone who's had a previous adverse obstetric outcome needs to talk about the chance of that happening again. That probably includes most women, and we would recommend pre-pregnancy counselling for them. The second section was about medication. And prescribing in pregnancy is always tricky. If you are looking for a drug that is licensed for use in pregnancy, then there are only 5. And this is it. This is what's available to you. So licensed are labetalol, amoxicillin, diazoxide, Zonvia, and calcium. And everything else is not licensed for pregnancy, and the paperwork and the BNF would ask for caution. But all prescribing in pregnancy is a balance between treating the maternal disease and preventing fetal harm. But it's not even as simple as that. Because fetal harm can be real, or it can just be perceived based on supratherapeutic doses in rabbits. And the other thing to say is that if you fail to treat maternal disease, that in itself can cause fetal harm. And that's really important, especially in conditions like lupus. And we thought quite carefully about how we were going to present drug safety data in pregnancy. So this is not our guideline, this is the Crohn's and colitis guideline, the European guideline produced a few years ago. And we looked closely at this with our expert patients. And what they've produced is something that's very clear, where they've talked about risk during pregnancy and risk during lactation. They didn't address pre-pregnancy, which we wanted to do, but this is very easy to follow. But what the patients told us, and what we perhaps fail to appreciate, is that when you look at this table, what you see is risk, 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 and that's a problem. So this is what our table looks like. So this is just the bit on our antihypertensives. And what we've tried to do is talk about conception and pregnancy and whether that's important for the mother and the fetus, but also an overall statement. And we've talked about lactation, and we've provided some references. And what we've tried to say is safe, where it's considered safe. We've said unsafe where it's unsafe. And where we don't know, but we use it, and where there is use described, we've said limited data. So the key points on medication use in pregnancy are that we have said that we are happy and we have recommended that ACE inhibitors can be used up until conception. And then you must stop them in early pregnancy at the time of a positive pregnancy test. And the reason for that statement is that ACE inhibitors are known to be fetotoxic in the second and third trimester. And there was always a worry that use in the first trimester was teratogenic. But in fact, there's reasonable data, and when I say reasonable data, that's over 4,000 exposed pregnancies, which is as good as it often gets, showing that in fact, if you use ACE inhibitors in the first trimester, there's no increased risk of malformation compared to unexposed hypertension. So it's the hypertension that increases the risk of malformation, not necessarily the drug use. What we haven't said is the same for angiotensin receptor blockers, purely because there is no data. I cannot tell you whether they are safe in the first trimester. We have said avoid MMF, cyclophosphamide and thiazides, and we've included rituximab and eculizumab in the guideline, saying that although there is placental transfer of rituximab, there's no evidence it's teratogenic and can be used where risk outweighs benefit, bearing in mind we have very little data on long-term outcomes in the offspring. And for eculizumab, we've said that the benefits are likely to outweigh the risks and it should be used. Blood pressure, we were very lucky because Professor Lucy Chappell was part of our guideline authorship group, and she also authored the recent NICE guidelines on hypertension in pregnancy. So that enabled us to align both guidelines absolutely. So there's no conflicting guidelines between us and obstetrics. And it's a very simple guideline. It says that the blood pressure should be less than 140/90, both before and in pregnancy. To help people who maybe aren't used to managing blood pressure in pregnancy, we've also made a new addition to say that treatment for hypertension can be continued unless the blood pressure is sustained at less than 110/70. And that's because of a worry that actually low blood pressure is harmful. And that aligns with NICE guideline, but that's quite helpful because it allows you just to continue the treatment. Dialysis in pregnancy was probably the most difficult section to write, again, because we're limited to small cohorts. But what we've tried to do is make a distinction between women who are established on dialysis prior to pregnancy and those women who have dialysis initiated newly in pregnancy, because we feel that's an important distinction to be made. So if you're established on dialysis prior to pregnancy, there are small cohort data that basically more dialysis is better. And there's 22 patients come from a group in Canada, they're shown here, and it basically just shows that as you increase the amount of dialysis, you increase the live birth rate, you also increase other obstetric outcomes, positive obstetric outcomes, and this highest tertile with the highest live birth rate is dialyzing for more than 36 hours a week. So the Italian dialysis guidelines recommend a minimum of 36 hours a week dialysis for women established on dialysis before pregnancy. We haven't made that recommendation, and we have actually moved towards a urea target in pregnancy, because that allows you to adapt the amount of dialysis to residual renal function. So there was a urea target described nearly 10 years ago of 17.5 in pregnancy, a small number of women, but it basically showed that when your urea was less than 75, you were more likely to have a bigger baby and you were more likely to get to a safe gestation, so after 32 weeks. There's some more data that's more recent that's come out of Brazil, 93 women on dialysis, and that basically says if your midweek pre-dialysis urea is greater than 12.5, that's pretty sensitive for an adverse fetal outcome. And so in Brazil, they would dialyze to a midweek pre-dialysis urea of less than 12.5. And because that's the biggest amount of data and the most contemporary data, we've done that. And then you can adjust the hours accordingly in order to achieve that. But more dialysis is not necessarily better for all women. All the data on dialysis, all the meta-analysis data, don't include women who start dialysis after 20 weeks of pregnancy. So you can't apply this more is better to women necessarily newly starting dialysis in pregnancy. And in fact, the published data is limited only to 17 women who were exposed to either long hours of dialysis, 33 weeks in pregnancy, or 15. And in fact, when you're newly starting dialysis in pregnancy, increasing dialysis from 15 hours to 33 hours a week made no difference to pregnancy outcome. And then you're just limited with a treatment burden and a possible effect on residual renal function that may not return. So what we've said about initiating dialysis in pregnancy is that if you have maternal indications, well, they're the same as if you're not pregnant. The problem is that fetal indications for dialysis are likely to precede any maternal indications for dialysis. And the fetal indication for dialysis is that urea is fetotoxic. So this is just a study from 1971 describing how you can use urea to end a pregnancy. And what we don't know really is at what level of urea it becomes harmful to the baby. The data are old, the data reflect very, very old practice of more than 50 years ago, but the only data we have are from 1963 and 1968, which basically say that if urea is greater than 21.4, all babies die. If urea is greater than 18, then half babies die. And we know this, the urea being greater than 18 causing a 50% fetal mortality, is not true now and doesn't reflect contemporary obstetric practice. So there is no real consensus to the urea threshold, and when we initially wrote the recommendations we didn't make one, and then the feedback was that, well, we need to know what you do so we can do something similar. So there are only two recommendations in the literature, one from the Brazilian group that uses 17 as their threshold and one from the Canadian group that uses 20. So we have basically included both and said that we think you should plan for dialysis at 15 and start somewhere between 17 and 20, depending on maternal health, fetal health, whether there's polyhydramnios, what the trend in the urea is, and also the gestation, whether you've got to a point where it's safe to deliver rather than start dialysis. Pregnancy after transplantation, the most common question was, when is it safe to proceed with pregnancy? And the data are conflicting. There's two meta-analyses that look at this, one with 2,000 pregnancies in 2010 and one with 6,000 pregnancies in 2016. So you can see the rate of pregnancy is increasing in published literature. And basically, time is not very helpful. So in the first meta-analysis, basically you're more likely to have a baby, successful pregnancy, if you conceived within 2 years of your transplant, but you were more likely to have a complicated pregnancy. And then the later meta-analysis basically says that you have better outcomes if you conceive less than 2 years after your transplant or greater than 3 years. And it's probably because time is quite a poor surrogate marker of graft function, of hypertension and blood pressure control, of proteinuria and of the planning prior to pregnancy, all of which we know are important factors in pregnancy outcomes. So the recommendations that exist are the European best practice guidelines, which recommend a delay of 24 months after transplantation, and the American Society of Transplantation, which recommends a delay of only 12 months, but also states there should be no rejection, stable renal function, and they actually provide a creatinine cutoff of less than 150, and no fetotoxic drugs. So we have worded ours as a recommendation, so this applies to the majority of women, and we have said the following things probably in order of importance. So we've said that graft function should be stable, medication should be safe, and this is usually more than 1 year after transplantation. So that's just a brief overview of some of the key sections of the guideline, and thank you to the team involved, especially to our 3 expert patients who provided a wealth of qualitative data talking about the experience of pregnancy, dialysis and transplantation, and their qualitative data is provided as an appendix in the guideline. Many thanks.
Great, thank you very much indeed, Kate, for a great talk, and I'm sure you'll be happy to answer some questions. We've got a few coming in, and please everybody send in questions. And Liz, are you on the you're on the line as well to
I'm on the line
to answer? Great. Hi. So looking at the questions, the first one that we've got is from Claire Gardner, saying that the Italian paper stated that urea should be less than 12.5 midweek, and was this in patients that were anuric, or did it include patients with a urine output? And if either of you would like to answer that one.
So as far as I'm aware, it all comes from the big Brazilian cohort, and in fact it's a mixed cohort. They have new starters and women established on dialysis, and they put them both together and didn't distinguish. So the data says a combination of patients, this is a good thing to do. But the advantage of using the urea cutoff is that it allows you to adjust for residual renal function. So it is a threshold I use both in new starters and in women established on dialysis. And you'll find that in the women who have no residual renal function, actually to get their midweek urea down to less than 12.5 requires many hours. And in fact, a new starter that I have on dialysis at the moment, and she's only on three times a week for 2 hours. So she's only getting 6 hours of dialysis to achieve the same target.
Great. And there's a follow-up there as well, which I don't know if you can see that. That's from Claire, just something about the amount of dietary protein intake, but I presume that wasn't a big variable in the study, was it? Do you think the amount of protein intake affects what your urea target is?
Yeah, so there is, so there's some data. So the Italians are very interested in restricting dietary protein in pregnancy just to stop that urea rising. And the Canadians do not do this. So in CJSON coming up, there will be a debate between the two ways of managing pregnancy. The guideline, actually, it's not a separate statement, but the guideline we've written does talk about protein provision in dialysis. And we've recommended a higher protein provision in order for pregnancy health on the basis that we can provide dialysis. I think there's always a worry about restricting protein to delay dialysis, and I think there's no convincing evidence that it's a good thing to do in pregnancy, but it is advocated by some.
Great. And then the next, we've got a question from Joel Gleffin. What anticoagulants would you recommend for pregnant dialysis patients? Is there any particular issues in terms of what anticoagulants you would use, or you just use low molecular weight heparin?
Just low molecular weight heparin. You can't really use anything else in pregnancy. I mean, you'd use warfarin in someone with severe antiphospholipid syndrome, but we avoid warfarin, and you can't use the DOAC, so it is low molecular weight heparin.
Yeah. And then following on, Liz, as you're there, so there's a question about MMF being contraindicated in transplant patients. Why is that? So I guess it's teratogenic, but what would you say about MMF and transplant or lupus patients?
It's why pre-pregnancy planning is so important. You need to think about all the women in front of you and what drugs they're on, and if you routinely use MMF in transplantation, or they've acquired it because they're rejection, you've got to think about what you're going to advise them. And if they're on MMF, they need to be using effective contraception, and Kate's the expert on telling us what's effective contraception, because it is teratogenic, undoubtedly so. Just first trimester exposure is associated with very high rates of miscarriage and a marked increase in congenital abnormalities. So you really don't want to get pregnant on MMF. Which is why you shouldn't be on it. But if you need it for your transplant, then you should be on it until you're planning your pregnancy, and then normally we would swap to azathioprine, which is safe.
Great.
But it takes the risk. If you're on it for rejection, you've got the risk of increased risk of rejection.
Great, thank you. And then we've got a question from Sakashitu about terminating pregnancy. I guess that's a difficult conversation, but would you like to give some either Kate or Liz some kind of idea about when you would really try and suggest to a patient that might be the best option?
So I manage all kinds of medical conditions in pregnancy, and there isn't a renal condition that's an indication for termination in isolation. So it's just all about providing information about the level of risk that woman has, which sometimes is high and sometimes is low, and dealing with that risk as best you can, and her understanding that the pregnancy might not be successful. But I've never advised a woman with a kidney condition in isolation to have a termination.
Great, thank you. And then can you, a sort of factual question here, can you donate eggs for a surrogate pregnancy whilst you're taking MMF? Is there a risk to the actual ovum, or is it just if when the
I mean, just
pregnancy
we
goes
don't
ahead?
stop it when they're going for IVF either. It's strategenic to the embryo. So yes, they can do that. Kate, you may disagree. There was some nonsense about sperm, but I think we're ignoring that.
Yeah, there's lots of nonsense about sperm, and I ignore it all.
Great, thank you. And then we've got I think that's more of a comment from Joyce there about ethnicity and body build in dialysis targets. I mean, would either of you say that in dialysis targets for pregnant ladies that ethnicity or body habitus plays a role in what targets you set, or is it one urea fits all?
I mean, given that the data are so limited, that the best data we have is the cutoff of 12.5, and it's never been corrected for ethnicity or body build. I don't know whether that has a bigger influence on creatinine rather than urea, and obviously creatinine is not a factor here, but it's one size fits all because it's the best we have.
I think that's a very practical point, in that we are more likely to be dialysing someone who's starting dialysis in pregnancy than an established dialysis patient who's pregnant. And I think that the slight worry about the fantastic data from Canada is, you know, you've got to do masses of dialysis. And as Kate has stressed, when they start and they're starting in pregnancy and they've got residual function, you often need very little. So we always start very gently, about 2 hours, 3 times a week, and build it up. We don't go straight to 6 hours, 6 times a day. Well, we never get to 6 hours. But we don't, you know, we don't go to 6 times a week rapidly at the start if you're initiating dialysis.
Great, thank you. And then we've got a question on, another factual question on rituximab. Would you still say don't conceive for 12 months after rituximab? What's the latest advice on rituximab?
Well, there's what the drug companies say, there's what we say. So it's not licensed in any shape or form. Actually, we say the opposite. If you've got a disease that's maintained on rituximab, you want the benefit of rituximab whilst you're pregnant. So certainly those on maintenance rituximab for vasculitis, we say try and get pregnant as soon after taking it. And the data are that obviously the baby becomes B-cell deplete, but I don't think they do if you give it in the first trimester. So I've actually recently given it to a couple of lupus patients in the first trimester to try and get control that lasts through the pregnancy. There's no evidence of traumagenicity, and the real advice you have to give is about no live vaccines in the first few months. But apart from that, there's really nothing to assess adverse events. We try and avoid it in the second and third trimester if we can, but I would never tell, because the problem with saying wait a year is whatever benefit you're getting from it's gone, and then you're back to square one with whatever you're trying to treat.
Yeah, no, that makes sense. And then we've got a question from Graham Lipkin, which is along the lines of something I was going to ask. That's great. I don't have to, but it's about the access to the MDT. So that's on the chat thing rather than the Q&A. So is variation in access to expert pre-pregnancy advice acceptable? Should there be, you know, networks to make sure that is it a bit of a postcode lottery in terms of what access people get to the MDT?
I think Kate's best placed to answer this.
Yes, so it is. There is a postcode lottery, and we would have really liked to make it a recommendation, because we felt that actually, if you make it a recommendation, you know, if you build it, they will come, and it probably should be available for the reasons I've given. What is coming in the country are maternal medicine networks, and so there will be an expert centre in each region that all the peripheral hospitals will have access to. So that was due to happen next year. I think that's probably not going to happen due to coronavirus. But once there are established maternal medicine networks, there should be capacity to provide multidisciplinary pre-pregnancy counselling throughout the country. And at that point, I think it definitely should be a recommendation.
But right. I will say that in the meantime, we're a fantastically collaborative bunch, and there are experts all up and down the country, and just pick up the phone or email your friendly local expert who'd be very happy either to see someone or give advice.
Great, thank you very much for that, both of you. So thanks for an excellent talk and discussion. That's great. I'm now going to hand over to Katie Fielding, who's going to introduce our final talk.
Thank you, Mike. So our final talk is by Damian Ashby, and he's going to be talking about the haemodialysis guidelines that were recently released. So Damian's a consultant in Hammersmith Hospital and has been since 2011, and he's also a senior lecturer at Imperial College in London. And he does have research interests in haemodialysis, anemia, nutrition, in kidney disease, and he's also the lead author of the Haemodialysis Renal Association guidelines. So I'll hand over to you, Damian. Thank you.
Thank you very much. And many thanks also for the opportunity to talk about the guideline. The Renal Association has had a guideline for haemodialysis for about 25 years. But at the time we were writing this, it was a 10-year gap since the last iteration. So there was plenty of new ideas and things to think about. I'm going to highlight just a few areas where there's a difference between the recent guideline and the previous one. Some areas where that's totally obvious, and in some areas where that's a little bit more subtle. So ensuring that there's an adequate quantity of dialysis provided has always been a major focus of haemodialysis guidelines. And we thought that a numerical measure would still be useful. And this section is in some senses changed very little. That's partly because the literature in this area remains still dominated by two quite old studies. The first of these was the National Cooperative Dialysis Study published in 1981. This is the first big randomized study of dialysis quantity. It was done in a 2x2 design, allocating to high dose versus low dose dialysis, as well as allocating to long versus short duration of dialysis. And although it's amazing really that we're talking still about a study that's nearly 40 years old, this study actually gave us so much. It was the first study that showed that the quantity of dialysis delivered matters, and it matters very much, with a very big difference in outcome in the groups. It also was the study that told us that dose was probably more important than time. Time matters, but mostly because when you increase time, you're actually increasing the dose of delivered dialysis. It also was the study from which grew the way in which we measure dialysis dose. Prior to this study, and in the planning of this study, it was averaged urea level that mattered, that was considered the marker of dialysis. Whereas out of this came the idea of urea clearance and the concept of KT/V, which we're all now so familiar with. And it also gave us the idea that there's a threshold for dialysis, that it matters that you get dialysis up to a particular level of dose, but going beyond that perhaps doesn't matter. Then, of course, there was the more recent, although this is still an almost 20 years old study now, the HEMO study. This was a nearly 2,000 patient randomized study, allocating people in, again, a 2x2 design that tested both flux as well as dose, but the dose was separated out into those with a KT/V of 1.05 and those with the higher dose of a KT/V of 1.45. And they achieved good separation, and there was a follow-up of almost 3 years, and this was a negative study with very clearly no difference in survival or in several secondary endpoints. So this study very firmly gave us the idea of threshold for dialysis, that it's important to get up to a certain amount, but going beyond that doesn't help you. Neither of these studies has been superseded properly since then. So the advice for the amount of dialysis measured by KT/V remains what it has been in most of the previous iterations of the guideline at 1.2, chosen to be just comfortably above the low dose arm of the HEMO study. The calculation methods, though, have always been quite fragmented, and even if you're reasonably numerate, these are completely complex enough. So we thought it would be useful to simplify. Most of the research is based on EKT/V, that's the equilibrated version, and therefore this is thought to be most valid for the guideline. We did provide a mathematical appendix that gave you a simple summary of the calculation methods and an argument for why this is the most useful one. It doesn't mean that other methods can't be used in individual units, but we thought it was time to stop giving the guideline recommendation in terms of different calculations. There was within the HEMO study, perhaps slightly overlooked initially, a noticeable interaction between gender and the optimum dialysis dose. It was suggested in that study and then subsequently confirmed by larger observational studies like this one, which covers 10,000 patients over a number of different countries. The different KT/Vs, so dialysis dose increases as you go to the right of the graph, and mortality is given on the left-hand side. And you can see a reduction in mortality as you pass a threshold of 1.2 for men, which then stabilizes, whereas the picture looks slightly different for women, where there isn't quite there's no real clear plateau. And it's possible that the threshold for dialysis, if one exists, is at around 1.4 or maybe even higher. So it's likely that the optimum amount of dialysis might be a greater urea clearance in women and possibly even also smaller patients, but without a definition of small. This issue, though, resolves itself to some extent when you look at the issue of time. In the NCDS study, time seemed to lose out to some extent to dialysis dose. And within the Hemo study, they didn't actually look at time. As dialysis had become more efficient over the 1990s, it was possible to deliver quite high doses of dialysis in relatively short time. So within the Hemo study, even the high dose group were receiving just under 11 hours of dialysis per week on average. Hence, when this study was negative, one explanation was that there were in fact very short times in both of the groups, and the idea emerged that time might be independently important from dose. And a number of large, more recent observational studies have supported this concept. For example, this is a DOP study from 2012, looking at, in particular, the duration of dialysis sessions in those on thrice weekly dialysis. You can see, for example, the large variability extending from America, where the majority of people are receiving less than 4 hours of dialysis, to Australia, where actually over 4 dialysis is occurring in more than half of patients. And this study observes a mortality difference related to time, with something like a 6% relative risk reduction for those receiving for every sort of 30 minutes extra of dialysis. Although it's observational data, it's quite powerful and it's a large study. And it does seem clear that a minimum duration for optimum dialysis does exist. And it's probably close to 4 hours. For large patients, setting a threshold like this makes absolutely no difference, because you'll usually be dialysing them for at least 4 hours in order to get the dose sufficient. The main effect, therefore, is on women and smaller patients, for whom it means not reducing below 4 hours, despite the fact that they might be achieving what looks like a very adequate KT/V. And this is completely appropriate, since, of course, the optimal dose might well be higher for this group in any case. So we've recommended a amount of dialysis that achieves both a KT/V target as before and an hours target as before, but with a firmer and clearer idea of why that's done. So on dose and time, so far the guideline looks very similar to the 2009 version. But the section that follows this is one on non-standard schedules, which provides a number of caveats for interpretation and a bit more context. For example, these dose targets only apply to thrice weekly dialysis in patients with minimal residual function. Incremental dialysis is based on the common sense idea that the amount of dialysis that you need for optimal outcome has got to be less for those with significant residual function that contributes than for those without. But the latter group is actually larger and makes up the majority of those studied. Therefore, the studies might not be applicable to all. Twice weekly and reduced dose dialysis co-evolved with standard schedules, but they tended to fall out of favour, in part because of the development of standards for dialysis dose, which assume minimal function, and also in part because these, at least in the 90s, were frequently used inappropriately when it was a resource limitation exercise. And although observational, there is a small supportive literature. For example, this is a 2016 study of incident hemodialysis patients who all survived the first year, within which there were 350 dialysing twice a week. These were then matched to a larger group that were dialysing thrice weekly, matched for age, comorbidity, and residual function. And you can see that over a period of years, there is no detectable survival disadvantage between these two groups. When you look at particular subgroups, you can see that there might be disadvantages in some subgroups, such as those with lower residual function, less than 3 mils per minute, and those with higher weight gains. So in particular, if you excluded these subgroups, you could be reasonably confident that there would be no mortality disadvantage from dialysing twice a week. Adding that to then the reduced treatment burden gives you a powerful argument for reducing dialysis, and then incrementing it, of course, as residual function declines. But in fact, in these groups, it's also possible that an advantage is a slower reduction in residual kidney function by dialyzing less frequently. Additionally, these dose targets only apply to thrice weekly dialysis in patients for whom survival is the primary goal, which you often assume that it is. But as dialysis has expanded and the patients and their treatment goals have diversified, not everyone, of course, is aiming for maximum longevity. And the guideline then has a section, therefore, termed conservative schedules, which focuses on the perspectives of the frail patient and discusses the circumstances and rationale in which it might be entirely appropriate to either reduce or totally disregard numeric targets for dialysis dose. So in writing this section, we find ourselves again reflecting on the famous quote from William Osler, that it's much more important to know what type of patient has the disease than what type of disease the patient has. I'm not exactly sure what the context was, but even though it's over 100 years later, it still seems remarkably apt. So this section is numerically very similar to the guideline from 2009, but subtly different in that it provides quite a bit of extra context so that it can be interpreted correctly. But there are also some sections that are completely new. Not many people will remember working with acetate dialysis, and the only comment given to dialysate in the previous guideline versions has been the idea that you should phase out acetate dialysis and move to bicarbonate. But actually bicarbonate dialysis has been standard now for probably over 20 years. During this time, some dialysate constituents have gradually become standardized. For example, glucose has gone from nothing to pretty much 5.5 millimoles per litre in all dialysates, and calcium's gone from quite high levels to around 1.25 in most dialysates. But other constituents, like potassium, for example, have diversified. Historically, there wouldn't have been any or very little amount of potassium in the dialysate, but as dialysis become more efficient, and also as the typical patient has become older, zero potassium dialysates have disappeared, and suppliers now give you a range of concentrates with potassium between 1 and 4 millimoles per litre. Whilst high potassium very readily springs to mind as dangerous, both low and high levels are associated with risk in modern studies. This study, for example, of 70,000 patients shows the U-shaped relationship between potassium level, pre-dialysis, and all-cause mortality, with mortality increasing outside a range of something like 4.3 to 5.6. After adjustment, though, for comorbidities, it's only high potassium that carries the risk, although that is with the caveat that the less than 4 potassium here is quite a large category and not subdivided. Potassium level, of course, follows a sawtooth pattern during the week between the interdialytic and dialysis periods, and this underpins some of the arrhythmia risk, which also follows a similar pattern. We're all now quite familiar with the Monday effect, which is undoubtedly associated with high potassiums. This is a 1999 study of over 1,000 hemodialysis patients on a Monday, Wednesday, Friday shift who died, and the causes are classified into sudden cardiac death, which are in black, other cardiac deaths, which are in white, and in grey, non-cardiac deaths. And you can see that whilst non-cardiac deaths are equally likely to happen on any day of the week, the cardiac deaths are all very much overrepresented on the Monday, especially sudden cardiac death. But as well as high potassium, low potassium risks are also evident. This is partly suggested by the timing of such events. This is a 2006 study of 80 hemodialysis patients who had a sudden cardiac death, and the time is given in relation to the dialysis schedule. You can clearly see that there's a sort of weekend effect with a high risk in this period when it's a long time since your last dialysis session, but there's also a higher risk in the during and immediately after dialysis session relating to low potassium. Also, the risks of low potassium are highlighted by studies which suggest there's a harm from low dialytic potassiums. This is a DOP study from 2012 of sudden death in 500 patients matched with control patients dying of other reasons. The last potassium in the serum in these patients who died of sudden cardiac death is slightly lower than the controls, but in particular, they're twice as likely to have had their most recent dialysis session on a low potassium dialysate. Larger DOPS studies also support this suggestion of harm from low dialysate potassium. This is a study of 30,000 patients from multiple countries. You can see the wide variability, for example, ranging from Germany, where higher potassiums are used, to Spain, where most people are still dialysing on a dialysate potassium of 1. And this DOP study, plus the one that came after it, showed that whilst there's not so much difference between a dialysate potassium of 2 and 3, there is a relationship between low potassium and mortality. And in particular, the potassium of 1 has a clearer high mortality associated with it. So it's reasonably clear that a mid-range potassium is optimal. So we kept to the 4 to 6 target. You could in fact argue that the upper limit could be a little lower at around 5.6 that we had in the 2009 guideline. And it also seems that higher dialysate potassium is preferable, so long as the pre-dialysis potassium is still controlled up under 6 in the serum. And probably this is what's driven the trend over the 5 DOPS phases towards higher dialysis potassiums. We also felt that dialysate potassium should be individualized rather than standardized across the whole unit, which is the approach that most countries take, although there are some notable exceptions, like Japan, for example, where even in DOPS phase 5, 100% of their patients are on a dialysate potassium of 2. Another dialysate constituent is the bicarbonate, or the buffer. This is slightly different from potassium, although there are some similarities. Dialysate buffer levels vary a lot between units, and plasma bicarbonate is again associated with outcome. This is a 2006 study of 50,000 patients, and it shows a J-shaped relationship with most of the increased mortality occurring in the unadjusted data at high bicarbonate. But after adjustment, you get a more U-shaped curve, with then most of the risk occurring at the low bicarbonates under 21. But this literature is difficult for a number of reasons, in particular the unclear definitions. Dialysate buffer comes mostly from sodium bicarbonate, but there is also a contribution from the acid concentrate, which contains acetic acid. There are some others that are occasionally used, but acetic acid is the commonest. Acetate is buffered by bicarbonate, or if you prefer the Stewart methodology, it reduces the strong ion difference. Therefore, some of it associates with hydrogen forming water and carbon dioxide. So if the initial bicarbonate in the dialysate is 35, and that is supplemented by an acetate of 3, the final bicarbonate that you get is 32. Sometimes these are distinguished by people using the terms actual bicarbonate or final bicarbonate. But we felt that the total dialysate buffer remains the same. Therefore, this has a more clear and unambiguous meaning and might be better to refer to. It's the same as the actual bicarbonate, which is probably the more common usage. So there's therefore a question of whether, for this group of patients who seem to be at increased risk with a low serum bicarbonate, whether increasing the dialysate buffer in patients in this range would improve outcome. There's large observational data sets that help you make a decision on this. But before we come to that, the bicarbonate depends on many factors. And unlike potassium, where lowering the potassium in the dialysate does lower the pre-dialysis plasma potassium, it's not at all clear that increasing the dialysate buffer actually increases pre-dialysis plasma bicarbonate. Coming to the DOPS data from 2013, you can again see quite a bit of national variation in dialysate bicarbonates, with 35 being the commonest. For example, with 2 extreme countries here, Germany and the US, with sort of 32 being the commonest in Germany and 38 being the commonest in the US. But this study also shows that regardless of the serum bicarbonate, that the higher dialysate buffers are associated with increased mortality. Therefore, it's not clear that the dialysate buffer should be altered on an individual basis at all, and out-of-range bicarbonate is probably better addressed by attention to diet and dialysis dose. Previous hemodialysis guidelines haven't had a section on fluid, though obviously this is very important. They have often referred to fluid aspects such as intradialytic hypotension in sections on prevention of adverse events. And they've also referred to strategies which preserve residual renal function, which is mostly about fluid management. But the importance of careful fluid control and accurate target weight setting is increasingly being recognised. For example, from this 2015 study of over 10,000 patients on in-centre thrice-weekly dialysis, around 15% regularly finished dialysis 2 kilos above their target weight, and around 7% regularly finished dialysis more than 2 kilos below their target weight. And mortality increases progressively, whichever way you make the error. So so both fluid overload at the end of dialysis and underload, if you like, are associated with mortality. Clinical assessment of target weight is notoriously inaccurate, and various methods have been suggested over the years, including probing for dry weight, but this is probably harmful and certainly causes symptoms. There's therefore much interest in technology solutions which might be able to assess hydration objectively. Methods tend to fall into one of a number of categories, like imaging, for example, inferior vena cava diameter measurement, biochemistry, such as using natriuretic peptides, electrophysiology, such as bioimpedance, and dynamics intradialytic measurements like blood volume monitoring. Lots of publications address one or more of these methods, and there are several detailed reviews available. Quite a lot of these studies suffer from the limitations of self-referencing design. For example, this is a Czech study of 50 patients where bioimpedance was used to assess hydration status. They found a quarter of the patients were overhydrated and roughly a quarter of the patients were underhydrated when using bioimpedance. And of course, over time, using this knowledge, they were able to correct this. But it's a bit like showing that when you can use bioimpedance mostly to improve your subsequent bioimpedance readings rather than leading to a benefit that's real and clinical. Improvement in clinical outcomes has been much harder to demonstrate. For example, this is a 2017 study of just 32 patients in a crossover design where they used blood volume monitoring to inform fluid removal during dialysis. But they found that this produced no difference in terms of intradialytic hypotension occurrence or the occurrence of associated symptoms. So we thought no recommendation could be made over a particular method, but we have suggested that clinical assessment is so difficult that it should be supplemented with some kind of validated objective measurement. Regardless of the final volume achieved, also it appears that the rate at which that volume is achieved is independently associated with outcome. This is a 2011 study using data from the HEMO study, those 2,000 patients, and here they're separated into 3 groups by the ultrafiltration rate. And using ultrafiltration rates which are high, so over 13 mils per kilo per minute, is associated with both admissions to hospital and mortality. We felt that it was premature to suggest a maximum ultrafiltration rate, however, which might have unintended consequences such as not achieving your target weight. And instead, we suggested an approach to high UF rates, which focuses on session length and interdialytic fluid gains. Of course, when you start to think about interdialytic fluid gains, you start to think about dialysate sodium and the possibility that a lower sodium in the dialysate might be a means of reducing thirst and fluid gains in the interdialytic period. There are several small studies and then one large observational study that confirm this principle, but the latter also offers a note of caution. It's a DOPS study from 2012, in which 90% of the patients are using a dialysate that's somewhere between 138 and 142. You can see extreme examples here, Germany and Japan, Germany favouring lower dialysate sodiums and Japan favouring higher ones. As expected, the lower dialysate sodium is associated with reduced fluid gain. But firstly, the effect is quite small. It amounts to, if you reduce dialysate sodium by 2 millimoles per litre, patients tend to come in about 0.1 kilos lighter. But more importantly, there's a suggestion of possible harm with, regardless of the plasma sodium, tendencies towards higher mortality in the low dialysate sodium group. So the recommendations on fluid don't include a dialysate sodium. They include a number of things. In particular, They include a suggestion that patient involvement is key and that therefore the adoption of patient-friendly terminology might be helpful. So we had guideline sections by this stage on dose, on schedules, on convection, on fluid, on dialysate, anticoagulation, and indeed safety. But it still felt like something was missing. So we then created a section focused on patient experience. And this includes a number of things which don't fit neatly elsewhere, including in particular home hemodialysis, which has been expanded to give a hopefully helpful set of practical advice covering the availability of home hemodialysis modality, as well as training, governance, staffing, and other things. Much of this is broad and, as is common with this type of advice, based on the experience of specific authors rather than on published evidence. This replaces the 2009 guideline, where the only real mention of home hemodialysis was that it should be available. Some things have been removed from the guideline altogether, such as water treatment, and that's mostly because it's been moved into a separate guideline because it has separate groups of people interested in it. And as before, several aspects of hemodialysis are dealt with in separate guidelines, including when to start, vascular access, nutrition, mineral metabolism, cardiovascular risk, transplantation, bloodborne viruses, and anemia. All of these topics that affect dialysis patients, hemodialysis patients, are covered well in other guidelines. We were well aware, writing this, that there are many, many excellent renal units in the UK and that there is no one single definition of correct. So the aim, writing this, it was increasingly clear to us, is not to eliminate variation. Only those aspects where there is broad consensus that some of the variants are probably harmful should be altered. It's a bit like most of us are not civil engineers, and yet we do know what a good bridge looks like, and we can probably recognise a scary one. So the aim of this was to write down some of the essential essence of a good bridge without saying that all bridges need to look the same. Up until 2007, the Renal Association guidelines were in fact termed standards. And we've tried to move away from this rulebook concept towards genuine advice with logical principles and proper explanation. So in conclusion, the newest iteration of the hemodialysis guideline is numerically in fact very traditional. But it does have quite a bit of new scope in terms of new sections, for example, covering dialysate, covering fluid management, and expanding the sections on patient experience. It's also, however, quite evolved in style, with a lot of simplification, including the mathematical aspects, a lot of context that allows you to appreciate patient variation, and a slight change in tone away from the concept of rules and standards towards genuine guidance. It, of course, was written by a very large author group, which I chaired, but most of the sections were already, I had first drafts from other people. So many thanks to the very large group. Thank you for your attention.
Lovely, thank you very much for that, Damian. That was a really good presentation, and I think you also very succinctly went over some of the evidence behind the recommendations as well, the guidelines as well, so that was great, thank you. I've got a few questions on the question and answer tab just to go through with you. The first one's asking, do we have guidelines for SLED? So I was just wondering, Damian, was there anything on SLED in the hemodialysis guidelines at all?
Was there anything on what, sorry?
On SLED, slow low efficiency dialysis.
No, there was a section on augmented schedules, so that would largely be covered by that, and that went through some of the studies of, say, frequent dialysis and nocturnal dialysis, and I suppose that covered some of those concepts. Those weren't recommended for particular groups, except for perhaps those who weren't achieving their targets on a more standard schedule.
Yes.
One of the difficulties with that data is a lot of it looks at overall mortality rather than looking at situations where it might be useful. And in fact, if you're not achieving dialysis targets on a thrice weekly schedule, you probably don't need to move to a say nocturnal dialysis or something very frequent. You could probably have quite a modestly augmented schedule, say 4 times a week, and that would be enough. Modestly augmented schedules, though, don't get a lot of coverage in literature.
Right, okay, so you're thinking more as around maybe just slightly more frequent dialysis rather than having to go for SLED for something like for chronic patients.
That's right, yes.
Yes, fantastic. I am aware, just out of interest, there is something, I think SLED is mentioned in the AKI guidelines, and there is a little bit about SLED in the AKI guidelines and its use for acute kidney injury, for the person who asked that question. There is also a question here around sodium profiling. So it's got down here, what is the evidence for sodium profiling to manage intradialytic hypotension? And if so, which type of profile is favourable, i.e. stepwise or linear? And any guidance on the start and end of sodium levels. Now, I know you mentioned sodium levels, didn't you? But I wasn't sure if that was about sodium profiling, but do you have any comments on that at all?
Oh, I suppose only limited ones. The evidence on profiling is limited, as it is on lots of aspects of sodium in the dialysate, and as it is on lots of methods which you might use to limit intradialytic hypotension. Given that we didn't find enough evidence to make a recommendation about sodium levels within the dialysate, we didn't really go beyond to look in detail at the levels for sodium profiling. We felt that that would be a step beyond. So we don't have sufficient evidence to make a recommendation about that. That doesn't mean that we think that people shouldn't be doing it. It simply means that we didn't think we had enough evidence to make a recommendation.
That's great, thank you very much for that. There's also a question here about bicarbonate in dialysate, where it's got, what would be your verdict regarding bicarbonate in dialysate? So I'm presuming this is whether there's anything about exactly what's needed. It obviously is quite complicated in terms of how bicarbonate in dialysate interacts.
Firstly, bicarbonate should be the main buffer in the dialysate, and the amount of total buffer within the dialysate should probably be between 32 and 35. We felt that there isn't enough evidence to suggest that this should be an individualized thing. Again, some people think that it's helpful for patients, and it doesn't mean you can't do that, but it means that if you're in a unit that standardizes bicarbonate and doesn't think about it, that's fine too. There isn't enough evidence to say that individualizing the bicarbonate in dialysate for different patients is a good thing to do.
So yeah. Okay, that's great. And then there's just one final question around EKT over V, where it says, is the EKT over V of 1.2 a practical aiming point or the goal of treatment? Hemo required an aiming point of 1.4 because no factors increased dose, every factor reduced it, i.e. e.g. downtime. So I think this is around what we aim for in practice to achieve an ideal, and is the 1.2 a practical aim, or is it what we want to achieve and we might aim a little bit higher?
Ooh. The difference seems to me quite subtle. I think that you should, the 1.2 is intended as a minimum. So if it's 1.4 or 1.6, that doesn't mean you're overachieving necessarily. There's also, of course, a time target as well. And if it was only 1.21 or something on a particular occasion, you are going to find that it varies. So I suppose I would feel that the 1.2 should be the minimum of the average of your randomly checked measurements of urea clearance.
Right, okay. So that's almost your goal. And you may aim a little bit higher to kind of achieve that every session.
If you knew that it was higher on one particular session, that doesn't mean that it's higher than that on every session.
Yeah.
A little bit like blood pressure. What you're trying to do is achieve an average that's within a target, not necessarily every single reading within a target.
Yeah. Okay, that's fantastic. Well, thank you ever so much for that, Damian. That's been really useful. And I think this concludes what has been a really great webinar, going through the content of the recommendations of the guidelines and also being able to delve a little bit deeper in them. I'd like to say thank you very much to our speakers for the presentations that they've given today, but also for the speakers and also the teams behind them who've produced the guidelines, because there's a lot of work that have gone into these guidelines to produce that. I'd also like to say thank you very much to my co-chair, Mike, for sharing this with me, and also as well, thank you very much for attending the session today and for all of the questions it's really produced a very interesting discussion. So thank you very much for that. I'm going to leave it at that. So thank you for attending and thank you for bearing with us because it has lasted a little bit longer. You'll see there's a slide on your screen that talks about the fact that there are CPD credits associated with this as well. But I'm going to conclude there. So thank you all very much.